Final speaker this afternoon is Dr. John Steinberg. Dr. Steinberg is a professor at Georgetown University School of Medicine, and he's the co-director of Center for Wound Healing at MedStar Georgetown University Hospital. Dr. Steinberg.
Jim, thank you, and Henry, thank you. Very inspiring. It's just so exciting for us to be here on Capitol Hill, and I hope that you all recognize the excitement that we have coming out of our jobs, and you guys see that every day, but it's just such a neat feeling. I get a chance to do this on occasion, and to have a chance to educate, discuss, or talk about an idea. I know you guys, this is your normal everyday routine, but for us it's just really exciting. So I'm excited to be here. I know Mr. Hughes and I got to chat a couple times during one of his last office visits when I bent his elbow and told him, come on with me to Capitol Hill and let's talk about your story. It's just so exciting to be here, and I really appreciate, Henry, your time and your dedication to come up with those fine words to really describe what you've been through, because I think you very well said that part of our advocacy here today is to make sure that everybody else has access to hopefully the kind of fine care that Mr. Hughes has had. Doesn't mean that he's had it easy, doesn't mean that it's been perfect, doesn't mean that he's got everything that he's want, but he certainly has had what we think to be the best possible outcome, and part of that's from the health care that he's had access to that others don't. So that's part of what we want to talk about. I'm going to show you a few gross pictures to make sure you're awake, and I'm going to wrap this up real quick because I know we're tight on time, and we'll try to get a couple minutes for questions. This is a below-knee amputation being performed the way we do it now, not the way Dave Armstrong showed it from 1901, but it still, as Dave said, is a barbaric operation, and my job as a podiatrist is to prevent my partners, the vascular surgeons and the plastic surgeons, from doing this surgery. The less I can keep them from doing this surgery, the better job I'm doing for my patients, like Mr. Hughes. So this operation, as Thomas Campbell said long ago, coming events cast their shadows before. This doesn't happen at 2 or 3 o'clock in the morning from an emergency diabetic foot amputation. You know what percentage of diabetic foot amputations happen for an emergency overnight? Good, because I don't either, but it's very low. The reality is that 90% of the amputations we do are scheduled and planned because unfortunately they've been declining for months. And we know that, we see that. They come to us at MedStar Georgetown University Hospital as a tertiary care center from all over Virginia, Maryland, and DC, when what they've been doing for so long has not worked. And that's the problem, is we need to get to these patients earlier. We need to bring these teams to these patients earlier so that we can intervene, because that simple sore, infection, ulcer, those warning signs are there for months and months and months before we end up having to do an amputation. Dave talked about the limb salvage team. These are some of the early warning signs that we see. Looking for this with Henry and other patients, looking at something as simple as a callus. For someone in this room that doesn't have diabetes and doesn't have neuropathy, a callus would be kind of a nuisance. Maybe a little painful when you play tennis. But for someone with diabetes, a callus is that early warning sign that unfortunately doesn't have pain because of neuropathy. That's the early warning sign. They have too much pressure in too small of an area, and that's going to become an ulcer. So that's where we go to work with our team to prevent this. Dave talked a lot about these slides, so I can skip over some of these, but we spent a ton of money on this, and the reality is that Medicare pays for the majority of amputations in this country. 2/3 of all amputations in the U.S. are financed by Medicare. So this has a huge impact on our cost of health care in overall U.S. dollars. Again, looking at reasons why amputations happen and why we should be so excited about intervening before it comes that time, is that 84% of all lower extremity amputations, all these below-knee amputations that we're here to talk about, these are preceded by an ulceration. And this is where advanced healing modalities, new drugs, better access to care, team approach to medicine can make a huge difference in outcomes. This is where we need to intervene. It's not at the time of amputation, it's way too late. So here's the example of what happens when that callus goes from being a simple callus to, wow, we got a problem. This is a blood blister for any of us that don't have diabetes and neuropathy, but for someone with diabetes and neuropathy, if you debride this down, guess what's underneath there? It's an ulcer. It's a break in the skin. This is the source of infection. This is how simple it is, and this is how it starts. This was a simple callus a few months ago. Now it's a blood blister, then it's an ulcer, then it's an infection. Pretty simple, straightforward pathway of how this works. A lot of it talks about mechanics. Mr. Hughes talked about Charcot deformity. This is what happens when your arch collapses. And that's what Charcot will do. When you have loss of muscle tension, loss of joint strength, and you have neuropathy, your foot will collapse. And that's one of the things that happened to Mr. Hughes that caused his pressure areas that led to ulceration. Simple mechanics that all of a sudden become not so simple when they go wrong. Here's a great example. Just like we've got beautiful weather radar maps on your smartphones, we can do that for foot pressure. Dave's a great pioneer in this. Dr. Armstrong has done a lot of work looking at plantar pressure assessments. Red's bad. Pressure's too high. We can put these little paper-thin inserts inside of someone's shoe and have them walk, monitor this on a computer screen. We can predict exactly where they're going to ulcerate. But the question is, do they have access to care to actually do something about it? And in this situation, it took a $300 pair of custom inserts that we need to replace every year or two, and this person now has no more red spots, decreased chance of ulceration, decreased chance of amputation. Getting $300 pair of inserts is a big, big struggle in today's healthcare environment. A very narrow wedge of Medicare patients in the diabetic shoe bill are approved for that. The majority of my patients that need these type of inserts can't get them. And $300 out of pocket is a big expense for every one of these patients. So big area for advocacy as well. We talk a lot about good wound care versus advanced wound care. As I said, I work at MedStar Georgetown University Hospital, which any of you who looked at the local news this morning or last night realize we're now a hospital without computers because we had a massive ransom attack on our computer system. So yesterday I got to do 8 surgeries, realizing how we did it in 1982 because we had 0 x-rays, 0 computers, 0 technology, not even email or calendar access. So pretty spectacular to see a hospital without computers. But in the computer age, we can do some pretty amazing things for advanced wound care. And the reality is that we need to advocate for bringing these technologies to our patients. One of the things that I do, and that Dave does on a routine basis, is diabetic foot surgery. And this is the kind of surgery that I prefer to do, is the non-amputation, non-infection surgery, where we can get to these patients who have the access that Mr. Hughes has, and we can take these situations of ulceration and pressure area, we can refine or do surgery to the bones or tendons and fix the ulcer. We can get rid of this bone spur and create a smooth foot. We can fix contracted hammer-toe deformity and prevent an ulcer on the ball of the foot. So there's a lot here that can be done with access to care and early intervention for these patients. A couple gross pictures here for you. This is a 39-year-old patient, diabetes, neuropathy, ulceration. This is an example of doing the same thing over and over again and expecting a different outcome. This is a patient who has an ulceration, treated for weeks and weeks and weeks or months. Doesn't look a whole lot different, right? So we have to realize this is not working. This is where the team approach and having multiple specialists involved in someone's care will say, hey, topical care, putting medicines on the wound is not fixing this. We have a pressure problem. We need to go and lengthen this person's Achilles tendon. So this patient who was non-healing ulceration for a year, it's a miracle he didn't get an infection and ended up with amputation, but he came to us after having a non-healing wound for a year in the same location with visits every week to his doctor. But it wasn't a team approach. It wasn't a multidisciplinary approach. There was no podiatric care. When we got involved, we said, hey, you need to have a 10-minute procedure called a percutaneous tendo Achilles lengthening, which means 3 tiny pinholes that I'm going to cut in the back of your Achilles tendon to lengthen that tendon. And look what we got in a matter of a month. We went from an ulcer that was there for a year to an ulcer that was healed in 3 to 4 weeks. It's just a matter of identifying the source of the problem. We have technology, we have surgical knowledge and ability now to fix a lot of these problems, whereas the other choice for this patient was to continue until that ulcer gets infected, and guess what the next step is? Dr. Armstrong's hacksaw. So the reality is this can have a different road. This is Mr. Hughes' foot. Henry, who just spoke to you a few minutes ago. This is what he has struggled with. This is his Charcot deformity. Here's his ulceration. Huge self-advocate, wonderful family, good access to health care, and I think a sometimes pretty decent doctor who was helping take care of him. But we still fought a difficult battle, a very difficult battle, and we're not done with this battle. But Mr. Hughes ended up with terrible gangrene of his digits. He ended up with infection on the bottom of his foot. We had to amputate 4 out of his 5 toes, and he still today is struggling with this wound that you see here. And we're working to heal those for him. So this is not a stop in, let's go fix this, and I'll see you next year. This is a constant struggle and a constant battle, and you're seeing a gentleman who really has the strength to continue that battle and has stayed on top of this from day one. Dave Armstrong talked to us about the importance of team approach. There is great data to tell us that, again, one specialty can't do this alone. The endocrinologist can help manage the blood sugar. The vascular surgeon can help with the blood flow. The plastic surgeon can help create a flap or a skin graft. Podiatric surgeon can help with the mechanics and the tendon and the muscle balancing. But it takes that whole team. We need 15, 16 different specialists involved to really make a difference in this so we can get the advocacy for these patients. When you start driving medicine by ego, saying, this is my patient, I'm going to take care of him, bad things happen. You have to have a team involved and realize the importance of that. So we can drive the amputation from what used to be below knee amputation to maybe a digit or maybe a midfoot amputation, which is much more functional, requires much less long-term health care costs, or has a much lower long-term institutionalization or need for prosthetics afterwards. So great advocacy we can do here, and then looking also again at realizing how we can decrease these major amputations from a team approach. At Georgetown, we have a tremendous group, and one of the things I wanted to help you understand terminology-wise is this limb salvage term that we've been throwing out. So wound care is part of limb salvage, but limb salvage kind of represents the assembly of the team. Anybody can do wound care. We can make decisions on what kind of Band-Aids to put on wounds, and nurses can do that, and doctors can do that, and nurse practitioners can do that. There's loads of wound care centers in the DC metropolitan area. But they're not our competitors. The busier the wound care centers get, the busier our limb salvage center gets, because we are the catch-all that catches those patients when they're not healing from the wound care centers. We are the tertiary care center. The idea is to push that out from being tertiary care. We need more wound care centers to become limb salvage centers, where they're surgically based and have the resources to do all of this in the community rather than having to come down to Georgetown and fight for parking space. So this is a quick list of who all is involved in our team. Our nurses and nurse practitioners and residents really are the coordinators and communicators. Dr. Armstrong mentioned many of these: vascular surgery, plastic surgery, podiatric surgery, which is our specialty, orthopedics involved for some of the major limb surgical work proximally, and then looking at all these other specialists that are involved. So big team, lots of numbers, but over and over again the data tells us the quicker we throw these resources at these patients, the shorter their hospital stay, the lower their costs, and the better outcomes. It really kind of makes sense when we look at how this works. We've published on some of this with Dave Armstrong and others, looking at the role of the podiatrist and the podiatric surgeon in what we do and what we bring to the table, and we feel that this is just so important. If any of you or any of your staff members should have some kind of crazed interest in wanting to hear more about this, I am co-director, and Dave's going to be a major speaker for us and also co-directs the meeting himself. But we have about 800 people coming to the JW Marriott Thursday, Friday, Saturday this week. Every one of you who would like to attend or have someone who wants to come for a few hours, we'd love to have you. We have a 3-day meeting with folks from 40 different countries coming to learn about limb salvage. We do live surgical cases where we beam live satellite footage surgeries from the Georgetown ORs into the JW Marriott, and just have a real neat. This meeting represents the team approach, because this meeting is not for podiatrists, it's not for vascular surgeons, it's for everyone, and it's really kind of a neat thing. Again, I zipped through this, but I would tell you, I hope you feel and understand the passion that we have as the physician providers, the passion that Mr. Hughes has as a patient advocate, and really the reality of the positivity of this message of what we can do when we assemble the teams and we have the right resources for the right providers. Thanks again for staying late here. We appreciate your time.